Good morning, everybody. I'll be talking on evolving paradigm of transcatheter mitral and tricuspid valve repair and replacement. I have no conflict of interest in this presentation. So if you see here, untreated severe mitral regurgitation is associated with increased morbidity and mortality. Mitral regurgitation begets mitral regurgitation, and 1 year mortality could be up to 57%. That's because there is increase of LV load, LV dilatation increases mitral regurgitation. Not all patients who require treatment get surgery. If you see here, only half of the patients get surgery even if they're symptomatic, especially when they get older, the treatment is denied. So classification of mitral regurgitation, there are two kinds. One of them is primary. The problem is in the mitral valve, which we discuss, anatomic abnormality of the mitral valve, which could be leaflet, subvalvular apparatus, chordae, or muscle. The secondary is because there is an issue with the muscle. So there will be LV dilation, annular dilation, which gives rise to mitral regurgitation. So prognostic determinant of MR depends on the severity, left ventricular function, as well as the symptoms of the patients. So this was 2017 ACC expert consensus in management of mitral regurgitation. Essentially, first you got to know how to make a diagnosis of mitral regurgitation, identification either by primary care or cardiologist. You do a transthoracic echo. You can do further non-invasive modalities to figure out the mitral regurgitation. Then you define whether it's mild, moderate, severe. Then you have to start the treatment. Usually the treatment is heart valve team, which includes cardiologist, imaging expert, interventionalist, a surgeon, and the entire care. So what you need to know is medical therapy. There is surgical treatment, which could be repair, replacement, also AFib ablation if these patients have AFib, and then transcatheter treatment, which is mitral valve clip I'll be discussing on, and then they need a regular follow-up also. So this is just the various types of mitral regurgitation. Again, based on the type of Carpentier classification, you can then make a diagnosis as well as treatment based on the type. This is another algorithm to say how mild to moderate mitral regurgitation can be diagnosed, who should be referred, when they should be referred, and the treatment they should be getting. So in this algorithm, who should be getting mitral clip is that patients who have symptomatic mitral regurgitation, which is primary, which is degenerated mitral regurgitation, and who have prohibitive surgical risk, they can get mitral clip, but the same thing for secondary, we'll discuss more. The general principle of therapy of MR, if it's primary, could be no medical therapy, and if there is symptoms, they should go for surgery, whether it's repair or replacement. The considered prophylactic repair for a low risk with long-term survival, means young patients who have prolapse, have a severe MR, no symptoms, you can consider repair in these cases. But what is important is when you have functional MR, they have to be on medical therapy first, consider also CRT, and then they should be considered either for surgery or percutaneous treatment. How did mitral clip get approved by FDA? The one trial that we need to know was Everest 2, which was a randomized clinical trial, was surgery versus clip. Device group was 1, 2 versus the control group was 1, and you see the follow-up was 30 days up to 5 years. And what did they find? That this device was very safe compared to the control, and effectiveness, we always knew surgery definitely was very effective compared to mitral clip. But if you see here at 12 months, 3 to 4 MR was seen about 18% of the patient on echocardiography compared to only 2% in surgery. But if you go on symptoms, the symptoms of NYHA class 3 was only seen in 1% in the device group compared to surgery. Essentially saying that these patients need to continue on medical therapy even after they get percutaneous treatment. Same freedom from death, MV, and surgery. The landmark analysis showed the crossover happened in the first 6 months. After that, the survival was same whether they got clip or they got surgery. Now coming to a case presentation, this is a 79-year-old female who had cardiomyopathy, multiple comorbidities, ongoing symptoms, on medication, and was very limiting with her activity. So if you see here, severe MR on echo, this is 3D echo showing that there is a combined, there's a prolapse of the anterior leaflet of the mitral, and here is the fluoroscopy, how to do a transeptal. This is a catheter entering into the LA. We had to place 3 clips. This is the final. In the 3D, you can see there is 1 clip, 2 clip, 3 clip. So we are able to actually trace the V wave when we are doing the procedure. So after 1 clip, this is the initial, which was showing a large V wave up to 80, went down to 50 after 1 clip, which went down to close to about 40 when we placed the second clip, and then went down to a mean of about 18 after the third clip. What's important before we, once we place the clip and we are about to release the clip, very important that we need to make sure that there's no gradient in the mitral valve. One thing you do not want to do is take care of the MR and give mitral stenosis. So this is a TVT registry outcome saying the same success rate. This is all comers in the registry, 92% success, in hospital mortality about 2.7%. And this is what happens at 1 year follow-up. And what you see, the mean age of 82 and STS score is about 6.1, means essentially these are very sick patients, elderly patients, and cumulative death as well as rehospitalization. If you see here, FMR usually does slightly worse than DMR. And what what did study show? That when you are treating patients, your mitral regurgitation has to be taken care completely. If you left residual mitral regurgitation, the outcome is poor, survival is poor. Also, concomitant tricuspid regurgitation is also a predictor of poor survival in these patients. 2 trials that were recently published, we had separate findings. One was, we will discuss both of these trials moving forward. If you see here, NEGM with a different result. One was MITRA-FR study. The design showed that if you see patients, total enrollment, once patients were diagnosed with mitral regurgitation, they were assigned either to medical therapy or to the treatment arm. And once they got the treatment, then patients were continued on medical therapy. So what did it show? The mitral clip success was about 96% or so. And as you see here, the procedural complications were very little. But clinical outcome at 12 months, primary endpoint death, hospital readmission or MACE, no difference between the 2 groups. This is the same thing at 12 months, all cause death and unplanned hospitalization, no difference. Co-opt study was done here in America, again, multi-center trial. Patients were randomized 1-to-1 mitral clip plus medical therapy and medical therapy alone. This is how patients were screened and randomized. Very important, if you see here, very strict criteria. Before they were randomized, patients had to be symptomatic. They were on, heart failure, definitely with BNP greater than 300. After treatment, had to be on good medical therapy. And I'll go over that, what it is. And look at the LV function was less than 50, but more than 20. And end systolic dimension had to be less than 70. So this is just the baseline characteristic saying these patients were very sick patients with multiple comorbidities in this group. So medication that were used, very important for general cardiologists to know that they were, most of them were on beta blocker, ACE inhibitor, nitrates, diuretics, all of these medications they were taking. And this is a major change in heart failure medication within 12 months. Means if did they tolerate and the medication had to be changed, it was about 6 to 7% or so, not a lot. So majority of them tolerated the medication. So what did the clip procedure show? That about 93% of, close to 94% of the patients had their MR reduced to less than 2+, which is essential. Like I showed you in the previous TVT registry, that you had to bring your MR to less than 2+ or even less than 1+. So guess what? Look at the results. That mitral clip definitely had better survival compared to GDMT, as well as this all-cause mortality, decrease in heart failure. This is combined death as well as heart hospitalization significantly lower in this trial, because it was a well-done trial. And very important, another event that we showed, that these patients who are on heart failure regimen, we know they are waiting for another definitive treatment, which could be waiting for transplant, LVAD. The need for that actually decreased in this group of patients who got a clip. So what did the MR core lab show? That patients with the mitral clip compared to GDMT, look at how the reduction in this patient when they came back at 30 days up to 12 months, was less than 5% or so. That is why these patients did very well. So if you see here, co-op trial result at 2 years and MITRA-FR trial at 1 year, the difference. Why was the difference between the two, MITRA-FR well as co-apt? The biggest difference is because the type of patients that were enrolled. If you see here, the co-apt trial enrolled patients with MR, but the LV EDP was not LV dimension, and diastolic dimension was not too bad. They did not wait for a LV to be dilated too much. So this is the term that the editorial viewpoint was proportionate versus disproportionate mitral regurgitation. So patients with co-apt trial had disproportionate MR, essentially LV and diastolic volume, if you see here, was lower, so the MR was higher. But what happened in MITRA-FR, the volume or LV and diastolic volume was higher, or we say what we call that burnt out LV. So when you reach to a stage of burnt out LV, even if you fix your mitral regurgitation, they do not respond well. This is another ongoing randomized trial which is going on everywhere. So mitral clip wins the FDA approval for secondary MR. That has been now approved by FDA, and we've been able to do this procedure. Going to the next one is, if they have prosthetic mitral stenosis valve, they have already a prosthetic mitral valve and there's a stenosis, is there a treatment for these patients? This is just to show you of a patient with NYHA class 3 who already had a mitral prosthesis, which you can see here, and there is stenosis of this prosthetic valve. Is there a treatment for this patient? Yes, we can go there and place a TAVR valve in that particular position. If you see here, a TAVR valve is being placed in the mitral position, and this is how it looks, final result. The echo showing that the valve was good. So we can do this kind of valves in certain kind of conditions only, not in all. You cannot do it in patients who have calcific mitral annulus. You can do it in patients who have valve in valve only, maybe valve in ring. So mitral valve repair, look at the landscape. There are several valves that are available. Some of them are in trial, some are first-in-man cases, many of them actually in the development. 2 valves actually are in the trial. One is the Medtronic 12 and the Abbott Tendyne. We actually are part of the, now going back to this valve, if you see here, there are various shapes and sizes because the anatomy of the mitral valve is very complex. So there's no one valve that will fit into that. This is the Intrepid Apollo trial. Mount Sinai is part of it. Actually, it's an apical axis, 35 French sheath, and this is primary, secondary objective, primary endpoint. So enrollment is ongoing right now. It is very slow because of the current situation, but we'll be able to get it going soon. Now, why Tmvr is very challenging? Because there could be LV obstruction. There could be perivalvular MR still left. there could be embolization of the valve, and right now it is still apical access. And other thing that you could have is coronary compression or LA injury. So there are a lot of challenges here. The question is, we know CLIP did well. Would co-op trial result affect the Tmvr trial design? We need to wait and see. So conclusion, DMR versus FMR, co-op to Tmvr is that mitral clip has been approved for prohibitive surgical patients. Very important, prohibitive surgical risk. About 400 cases are being done in the US. That was before the current situation. And it has now been approved for patients with the FMR who already are on guided medical therapy. Very important that they got to be on good medical therapy. They still have symptoms and MR. That's the time we can make sure they can get the clip. So Tmvr valve in valve using a Tower Sapien valve can be done for mitral bioprosthetic valve. For valve in a ring, we are not sure, but you can be considered. And Tmvr utilizing complete replacement of mitral MV. So far, mixed result. There are ongoing trials. We just have to wait and see what they show. Moving on to tricuspid valve. If you see here, there is a septal leaflet, anterior leaflet, posterior leaflet. This is a beautiful anatomy showing how complex tricuspid is. Going to the type of tricuspid regurgitation, primary regurgitation. This is the secondary tricuspid regurgitation, and what is called as isolated, where only I think there's atrial dilatation giving rise to TR. This is where you see a dilation of the RV giving rise to tricuspid. So functional tricuspid regurgitation, we know that if it is left-sided giving rise to the left-sided pathology giving rise to TR, anterolateral jet, but if it is AFib on top of RV involvement, it gives rise to posterior jet. So clinical outcome, we all know severe TR, worse survival and more cardiac event, especially if they have symptoms. And this is telling us that the lot of patients, about 1.6 million out there, but the surgical treatment is provided to a very minor population. What are the various surgical tricuspid repairs available? Is leaflet cooptation. You have stabilized annulus, and very important, avoid conduction abnormality. Various techniques that has been shown here, which are surgical techniques. So national trend and outcome in isolated tricuspid regurgitation. So over years, the number of tricuspid surgery has gone up, but still the in-hospital mortality is just about 8 to 9% shown in this particular paper. So what did it say? Isolated T-wave surgery is largely performed, although utilization has increased over time. Despite an increase in surgical volume, operative mortality has not changed. So given the increasing prevalence of isolated TB disease in population, research into optimal surgical timing and patient selection is critical, saying that some treatment option has to be provided to this patient. What are the various approaches? You have superior vena cava approach, inferior vena cava approach, transapical, transatrial, and this is what target we have to do. The tricuspid therapy wise, what is out there? Cooptation device, one of the important device I will show is a FOMA device. This is the clip. Now, heterotropic caval valve implant. This was the first treatment that was initially decided to be done for tricuspid cases. And then you have a tricuspid ring annuloplasty or suture annuloplasty. So various devices out there telling there's no one treatment that can be given to patient. When may a transcatheter preferred over surgery? All depends if the tricuspid anatomy is favorable and there has to be a good TE imaging. And RV, if they should not have pacemaker and RV lead is not in between inhibiting the cooptation. These are the various trials that are ongoing for tricuspid regurgitation. So long-term outcome of the one device FOMA, which I just mentioned initially, what did it show? That very small group of patients, but still at follow-up, if you see here, the severe TR actually went down, 33% decrease. And it's the same thing, vena contracta width, the size of the IVC also decreased at follow-up, saying that there was some promising result here. 1-year outcome of H2H repair, which is the clip that was done for tricuspid, is the same thing at baseline and follow-up. Significant decrease here in the tricuspid regurgitation. If the procedural success was there, you see that was a survival benefit in this patient who got the clip. This is the Triluminate trial, which was a pivotal trial. We were part of it, and right now a randomized trial is going on. This is the same clip that being used even on the mitral side. This is the first Triluminate case that we did here at Mount Sinai. If you see here, severe RV, RA, severe TR, the same thing being shown in 2D echo. Baseline TE, this is the first clip grasping, and we are trying to close the clip here. Compared to majority of the percutaneous procedure that we do that requires fluoroscopy, both the mitral clip as well as tricuspid clip does require a lot of imaging. Now this patient already had a previous mitral clip. So you see the mitral clip is here. Patient also had a ASD occluder, and this is telling you the anatomy. The anterior leaflet, septal leaflet, posterior leaflet, and how we are trying to grasp as we are going. This is the second clip that we are trying to place. And this is the second clip, which is already in there. You see here. So post deployment of, you see here, anterior septal, and this is the anterior posterior. So this is the mitral clip and 2 tricuspid clip that were successfully placed in this patient. So significant decrease in the tricuspid regurgitation. If you see, this is the pre-implant and this is the post-implant decrease in the tricuspid regurgitation after placement of the 2 tricuspid clips. This is mild to moderate TR when they come back at 30 days. So this is a randomized trial, which again Mount Sinai is part of. Patients have to be on therapy, and they cannot have pulmonary artery pressures higher than 70. And when they are screened well, we have been placing the patient. What are the other devices that are available out there? This is the Edwards Pascal transcatheter valve repair system. It is another one that looks like the clip. It's a little wider. This is also being used both for mitral as well as for the tricuspid side. The various coaptation devices, coaptation essentially trying to take care of the valve. FOMA repair system, which we already discussed. Then H2H repair using mitral system, and the Pascal, which I just showed you. This is just to work on the clip for the coaptation. This is suture annuloplasty, and here ring annuloplasty, another kind of a device that is available. This is a cable implant, which was the first one that was started, but right now not being used. This is a cardioband system, again, trying to put for the annular, decrease the annular size. So proposed algorithm, if it's primary or secondary, if there's prolapse, consider clip. If it's a rheumatic cause of tricuspid, consider a TTVR, and lead induced means you can consider either a coaptation problem or you can place a valve. Then secondary, again, various devices are out there. So it's not one particular treatment. Patient needs to be evaluated and then considered. Bioprosthetic tricuspid regurgitation, stenosis and regurgitation. Are we able to take care of this patient? Yes. This is a case who already has a bioprosthetic tricuspid valve, valve, and then had restenosis. So this is the previous valve, and we were able to place the sapien valve on the tricuspid area. This is how the final tricuspid implant looks. No TR with a mean gradient of only 5 post-procedure. This is the same patient algorithm for tricuspid intervention. If they're on medical therapy, if they're still refractory to symptoms based on what the pathology is, then we can consider what treatment can be given, whether it is H2H repair or various other devices that I just discussed. So Conclusion for TTVR take-home message is untreated severe TR carries a poor prognosis. Trichospeed repair with the remodeling annuloplasty is the current gold standard in surgery. Transcatheter repair is at its infancy. As I have shown you so many devices trying to say it's not one treatment that can be done. Leaflet cooptation or annular, decreasing the annular size is the way to go. Heart team approachment and early evaluation and maximize opportunity to offer entire spectrum of therapy, which includes medical, surgical, or transcatheter should be considered. Now, all these things that I've discussed, you can also watch many of these live cases on ccclivecases.org, which has been going on for over 11 years and structural for over 7 years. So if you see here, total page views per month are almost close to 30,000 or so. We are on the YouTube channel where you can watch these various live cases and understand how it what involves in referring these cases, as well as the treatment wise. We are on the Facebook, we are also on the Twitter, Instagram, and we have created several apps. These are mostly for interventional cardiology, but still anybody out there can learn based on this apps also. These are the cath lab apps with the several downloads that are mentioned here. And if you see here, they are free to download. You can either go to Google Play or App Store and download these apps. Thank you for your attention.